All right. Well, we may as well begin. People will trickle in slowly, but welcome to the Investigators webinar. So this event is recorded, but only our presenters will be on screen for the event. You are encouraged, however, to use the chat for discussion and questions. I ask that we all take a moment to acknowledge that the lands on which we work, live, and play are the traditional and unceded territories of the Beothuk, Mi'kmaq, and Maliseet peoples, and the homelands of the Innu and Inuit of Labrador. We should all recognize and appreciate the ancestral and continued ties of Indigenous people to the lands and waters in this region, most of us know as Atlantic Canada. We cannot engage in the work of addressing the health of 2SLGBTQIA+ people without considering the ongoing and historical impact of colonialism and settler structures on the First Peoples, especially those who are Two-Spirit. Canada is a nation that was built on the backs of Black people through slavery and a history of anti-Black racist policies. People of color have faced historical and continued oppression at personal, social, and structural levels. The history of white supremacy in Canada, North America, and globally has had long-lasting damage. We need to name that harm before we can begin to address it. As part of a historically excluded and systematically marginalized people, I seek to be an ally to others and hope you do the same. We all play a role in shaping a better world. So now I'd like to introduce everyone, starting with Kirk.
Hi, everyone. My name is Kirk Furlot. I use he, him, his pronouns. I am the CBRC Regional Manager for Atlantic Canada. I'm a white cis gay settler who has the privilege of living, working, and playing in Jibuktuk, Halifax, in Mi'kma'ki, in the ancestral and unceded territory of Mi'kmaq. I'm also just going to do a quick introduction to CBRC while I'm here. You're really not going to see me for the rest of the presentation because I'm not the star of the show. Those are our investigators. So what is CBRC? The Community-Based Research Center promotes the health of people of diverse sexualities and genders through research and intervention development. When we were founded in 1999, it was by and for cis gay men. We've expanded beyond that to better represent the broader 2SLGBTQIA+ community. Still room for growth. And we still have some projects specific for queer men, such as the Sex Now survey, the data source that our investigators have used. Investigators truly represent CBRC and how we came to be. Our founders were tired of research being done on or to them instead of with, by, or for them. So Investigators seeks to help address that by giving younger Two-Spirit, trans, and queer people a chance to do research by us and for us. We've expanded to other leadership programs since we've begun, such as Totally Outright, which is focused on health promotion, Pivot, which is focused on systemic change and advocacy skills, and Do You Mind, which is focused on mental health. We continue to be a community-led and community-focused organization. We are, fun fact, a nonprofit charitable organization. We're not like some big giant financial corporate conglomerate. Our main office is located in Vancouver, British Columbia, which is where we started. And we have offices in Edmonton, Toronto, and here in Halifax. CBRC couldn't do the work we do without our amazing community members and partner organization. Special shout out to all the partner organizations in Atlantic Canada who helped us collect data for Sex Now over the last several years that our investigators could then analyze. Special shout out to our local academic partner, Dr. Matt Newmer's Sexual Health and Gender Lab at Dalhousie University. And of course, tonight wouldn't be happening without the hard work of our local facilitators, Zach, Emily, and Alex, plus all our wonderful participants. I'm looking forward to seeing your research findings. Check us out online at cbrc.net, and please make sure to complete the evaluation survey we'll be providing at the end of this event. Thank you all for coming, and back to you, Zach.
So we'll just do a quick start. Who are we? So I am Zachariah Crawford, or Zach Crawford. I'm a researcher for CBRC and lead facilitator for Investigators. I'll just take a moment to let Emily introduce herself.
Hello, my name is Emily Kamau. I am also a facilitator with Investigators, and I work closely with Zach to make sure everything is running smoothly.
So just a start, what is Investigators? So Investigators is a participatory, community-based capacity building intervention that equips young, queer, trans, and two-spirit people with social connections, health knowledge, and community-based research skills they need to be health leaders in their communities. Launched in Vancouver in 2011, Investigators is now run in various cities and communities across Canada. Through the program, youth gain hands-on real-life research experience grounded in the principles of community-based research. Program participants learn about quantitative and qualitative research skills, social detriments of health, HIV prevention, and sexual health, and the utility of research in addressing health inequities and knowledge gaps. This particular group is our second version of the Investigators. I've been piloting the program in Atlantic Canada since 2020. The first one was kind of a rough go just because COVID had begun and we had to learn a lot to kind of keep everything going. We do try to keep this an in-person program, but unfortunately with COVID, there are times when we had to switch to online, and it's gone pretty well this time around. So how this will work is each investigator will present their work, and then there'll be a quick couple minutes for a quick Q&A. You can ask your questions via the chat, and one of us will curate them and share them with the investigator so they don't have to pay attention to the chat during the presentation. So we will now have our first investigator present their work.
So our first investigator is Jasmine Tang. So they're in their first year of, or their final year, sorry, of their Bachelor of Science in Biology and Psychology at Mount St. Vincent University. Their primary research interests are in queer health and wellness, and in how healthcare systems can change to better support the health of queer people. The project that they will be presenting is entitled Minority Stress, Community Connectedness, and Substance-Related Coping in LGBTQIA individuals. And it is an examination of how substance use as a coping mechanism affects the link between minority stress and psychological distress. Here's Jasmine.
Hello, everyone. Can you all hear me to start off? Lovely. All right. Can we confirm you can see my presentation?
You're good to go.
Perfect. All right. Hello, everyone. My name is Jasmine. Pronouns are they, them. And today I'm going to be discussing 4 different variables and how they interact specifically within a population of gay, trans, bisexual, queer, and two-spirit individuals. And those variables are minority stress, community connectedness, substance use, and psychological distress. So minority stress is the increased level of stress experienced by minority groups due to chronically high levels of discrimination, marginalization, and prejudice within society. Sexual and gender minority stress are generally separated into 3 categories, each of which can impact the others and the health of the individual. And those categories are internalized stigma, which are negative feelings about oneself adopted from the environment, stigma consciousness, which is increased vigilance and sensitivity to stigma, and lived stigma, which is experienced discrimination. So it's important to affirm that it's not simply being LGBTQ+ that is associated with negative psychological outcomes, but it is minority stress. Studies have found that poor mental health is associated with general minority stress, discrimination in the past year, anticipating discrimination, and experiencing microaggressions. And though all of these studies looked at different outcomes, ranging from depression to trauma symptoms to suicidal ideation and attempts, it is clear that a link exists between minority stress and psychological distress. And substance use is often used as a method of coping with that minority stress. One study identified 3 categories to which most of their participants attributed their substance use. And those were homophobia and heteronormativity in their environment, internal homophobia and feelings of compulsory heterosexuality, and the prevalence of alcohol in LGBTQ+ spaces. And as you may have noted, 2 of those themes align very closely with those categories of minority stress that we were just discussing. So as mentioned on the previous slide, LGBTQ+ individuals have noted the centrality of substances in LGBTQ+ events and spaces, and the perceived pressure to use substances in order to find support within the community. Studies have examined the relationship between community connectedness and substance use, but there have been conflicting findings. Some have found that higher connectedness to the community was associated with higher substance use, but others have found that this relationship didn't really exist. And on the other hand, connectedness to the LGBTQ+ community is essential to the psychological well-being of LGBTQ+ individuals. One study found that being connected to the community was helpful to participants in coping with the negative emotional impact of discrimination, as well as in providing them with ways to manage experiences of discrimination and ways to cope with potentially discriminatory settings. So with this information, I want to quickly run through how I define my variables using information from the Sex Now survey. So my substance use variable I defined as a dichotomous variable, so a yes or a no, and individuals were assigned a yes if they noted that they used substances in the past 6 months, and they used substances to feel better about things that happened because of stress about their sexuality or because of stress about gender identity or expression. And they were assigned a no if they did not use substances in the past 6 months, or if they used substances for a different reason. And this is because I really wanted to focus on substance use as a coping mechanism. My minority stress variable was a little bit more complex. So I assigned each individual a score based on their answers to these 5 questions, which cover things like anti-LGBTQ+ violence, discrimination, conversion therapy, comfort in certain environments, and the perceived impact of one's sexual orientation on their ability to achieve their goals. And so the higher each score that someone received based on their answers to these questions, the more minority stress they had experienced. And my final 2 variables were a lot simpler. LGBTQ+ community connectedness defined by an individual's answer to this question here, and psychological distress was the sum total of an individual's score on the anxiety scale and their score on a depression scale. So with my variables defined, I wanted to look at whether or not substance use mediated the relationship between minority stress and psychological distress. And this was basically a statistical analysis of whether or not substance use was an effective coping mechanism. So did it lessen the link between minority stress and psychological distress, or did it increase it and make it worse? My results were insignificant, meaning that substance use didn't really explain the relationship between minority stress and psychological distress, nor did it change it in any significant way. I then wanted to look at LGBTQ+ community connectedness as a moderator. My results here were also insignificant, and this means that for this population in this survey, being more connected to the community did not lessen the effect of minority stress on psychological distress as hypothesized, nor did it increase the link between minority stress and substance use, as some researchers have thought. I also ran a correlation analysis to see how each of my variables were connected individually. So community connectedness was significantly negatively correlated with my 3 other variables. And that means the more connected someone felt to the community, the lower their score in minority stress, psychological distress, and substance use. Minority stress, on the other hand, was significantly positively correlated with psychological distress and substance use. So the more minority stress someone experienced, the more psychological distress they also experienced, and the more likely they were to have used substances. And similarly, psychological distress was significantly correlated with substance use. And these findings largely affirm other studies that have been conducted with different populations in the LGBTQ+ community. So where do we go from here? My mediation and moderation models in this study were not significant, but my study did have some limitations. One big thing was that this study did not have any information on the intensity or frequency of substance use, and I think that this may have significantly changed the relationships that I looked at. Another thing is that the Sex Now survey only captures participants' answers at a single point in time. And this means that we can't really determine any causal relationships because we don't actually know if something like substance use began after an individual experienced minority stress or if it was a pre-existing habit. And this can be achieved through longitudinal research, which follows an individual through the course of time. And finally, quantitative analyses like this often fail to capture the complexity of an individual's experience. So qualitative research may be better suited to answer a question like whether or not individuals actually perceive their substance use as an effective coping mechanism for them. So there's still a long way to go in this area of research, but every study we conduct increases our pool of knowledge and helps make LGBTQ+ research more mainstream. So a big thank you to everyone involved in this process. It was a fantastic experience, and I'm happy to answer any questions.
Feel free to put any questions in the chat. I will read them out. Here is the first one, actually. How did you decide which questions to use in your minority stress variable?
Yeah, so if I can go back through my slides. So I wanted to expand my definition of minority stress outside of just discrimination, because as I mentioned at the beginning, there are a lot of factors that go into minority stress. And so I tried to determine any of the questions that dealt with any negative impact of someone's sexuality or gender on their life, or what they perceive to be a negative impact. So has your sexual orientation prevented you from achieving your goals? Things like that. I attributed more to the side of internalized homophobia, and obviously things like conversion therapy or discrimination or anti-LGBTQ+ violence were more attributed to the external homophobia and transphobia side of minority stress.
Fantastic. If anyone has any further questions, please put them in the chat. What qualitative questions would you ask to explore that further?
Yeah, so the big one, I think, what I would like to explore more is how LGBTQ+ individuals perceive their own substance use, and see how they think that helps with their coping or helps lessen the effects of minority stress in their life. So that would be a big one. Just how do you perceive your substance use as helping you, or things like why you use substances, just things that give individuals a chance to explain more of their own experiences rather than reducing it to just a checklist of why someone uses substances.
We'll give it one more minute before we move on to the next presenter. All righty. Thank you very much, Jasmine. That was fantastic. We will now move on to our next presenter. So up next is Jennifer Boone, she, her, is presenting the project Intimate Partner Violence Among 2SLGBTQ+ Men in Canada, Early Life Violence as a Risk Factor. This paper will explore early childhood experiences of anti-LGBT violence as risk factors for experiencing intimate partner violence in adulthood. Jennifer is in the first year of her Master's in Health Promotion at Dalhousie. She is passionate about addressing and ending sexual assault and intimate partner violence in all forms. She has volunteered at various organizations that address intimate partner violence and sexual assault, including Shelter Movers Ottawa and the Ottawa Rape Crisis Center. Without further ado, please begin, Jennifer.
Okay. Hello. All right. So yeah, my project today is intimate partner violence among 2SLGBTQ men in Canada, early childhood violence as a risk factor. So intimate partner violence is violence by a partner in an intimate relationship. This violence can take many forms, including emotional, sexual, and physical violence. Intimate partner violence is a significant issue within LGBTQ men's relationships that remains largely invisible within society. Estimates suggest that close to 54% of LGBTQ men will experience some form of IPV, which is similar to the prevalence rate of IPV for women in heterosexual relationships. However, a myth persists that intimate partner violence is exclusive to heterosexual relationships, with men being the perpetrators and women being the victims. This myth makes it difficult for LGBTQ men to recognize abusive dynamics and seek assistance. The lack of research on IPV in LGBTQ relationships both reflects and contributes to the invisible nature of this issue. Only 3% of the research on IPV so far focuses on LGBTQ relationships. So, LGBTQ men experience unique risk factors that can increase the risk of IPV. In Canada, sexual minority people experience higher rates of violence than heterosexual people, which can increase their risk of violence from a partner. 6 out of 10 sexual minority Canadians report experiencing physical or sexual non-partner violence at some point in their lives, compared to 4 out of 10 heterosexual people. This violence can contribute to minority stress, which is the stress of being a member of a minority group that is stigmatized and marginalized. Minority stress can lead to adverse mental health outcomes, lower self-esteem, shame, and psychological distress, all of which are risk factors to experiencing IPV. Minority stress can also negatively impact a couple's relationship, creating tension, poor communication, and maladaptive behaviors within the relationship, which can then increase the risk of violence occurring. So while most of the research on IPV so far and the risk factors among LGBTQ men focuses on adult experiences of discrimination, for many LGBTQ people, violent discrimination starts in childhood. 65 to 85% of LGBT children have experienced some form of bullying, including physical, verbal, and sexual assault. In general, experiencing violence as a child significantly increases the risk of physical and sexual assault as an adult and increases their risk of IPV. This suggests that anti-LGBT violence during childhood could be a significant risk factor for experiencing IPV as an adult. So this brings me to my purpose, which is to explore whether experiencing anti-LGBT violence during childhood is a risk factor for intimate partner violence as an adult. So to explore this, I use data from the 2019 Sex Now survey. The Sex Now survey, in this survey, they were asking questions about whether respondents had ever been targeted by anti-LGBTQ violence, which is broken down into 4 domains: physical, verbal, emotional, or sexual. Respondents were also asked whether they had ever experienced intimate partner violence, which was also broken into 3 different domains: physical, sexual, or verbal. So 5,997 people responded to these questions about whether they'd ever experienced anti-LGBT violence or intimate partner violence. And data was analyzed from the Sex Now survey using our statistical software. So what I found was that out of people who responded to these questions, around 44% had experienced emotional violence during childhood, 56% had experienced verbal, 20% had experienced physical, and 8% had experienced sexual, while 30% had experienced no anti-LGBT violence during their childhood. And so to determine the impact of anti-LGBT violence on intimate partner violence, binary variables were created for each type of anti-LGBT violence and for each type of intimate partner violence. 3 logistic models were then fitted, 1 for each type of intimate partner violence. And in each model, the variables of interest were the types of anti-LGBT violence that I had previously mentioned. So after fitting the logistic models, the odds ratio and confidence interval of each coefficient was calculated. what I found was that overall 41.47% of respondents reported experiencing some form of intimate partner violence. The most common reported form was verbal violence. Almost 37% had experienced this, followed by physical, around 17%, and sexual violence, around 12%. I also found that all 4 types of anti-LGBT violence during childhood were significantly associated with experiencing physical and verbal IPV. Emotional, verbal, and sexual violence during childhood were also significantly associated with experiencing sexual IPV. So this table shows the increased likelihood of experiencing each type of IPV due to a type of anti-LGBT violence. And the bolded numbers are those that were found to be significant. So for instance, individuals who experienced emotional violence as a child were 1.55 times more likely to experience physical intimate partner violence, 1.86 times more likely to experience verbal IPV, and 1.88 times more likely to experience sexual IPV. And similarly, for physical anti-LGBT violence, they were 1.83 times more likely to experience physical IPV and 1.47 times more likely to experience verbal. So the study examined the associated likelihood of experiencing IPV as an adult after experiencing anti-LGBTQ violence as a child. And there are several key findings. The first is that out of almost 6,000 participants, over 40% indicated that they'd experienced some form of intimate partner violence, which confirms previous research findings that IPV is prevalent within queer male relationships. The second key finding is that emotional, physical, sexual, and verbal anti-LGBT violence significantly predicted likelihood of almost all types of IPV. It is clear, therefore, that experiencing anti-LGBT violence as a child is a significant risk factor for re-victimization as an adult. There are some limitations to the study, as the majority of respondents were white gay men, which is not fully representative of the community, and so not fully generalizable to all LGBTQ men. Future research might want to explore how these findings change for different sexualities and ethnicities, as other research has shown that bisexual men are at higher risk of intimate partner violence, and minority ethnicities experience additional levels of minority stress, which could contribute to their risk. There are also several implications to the study. One is that addressing bullying at schools could be an early intervention to reduce risk of violence within the queer community and among queer adults later in life. And additionally, there's a need to educate and train service providers on the unique risk factors and prevalence of IPV among LGBTQ men so that they can provide supportive and understanding environments for men seeking help. Okay, thank you.
Fantastic. If anyone has any questions, please place them in the chat. What would you like to ask people to learn more about this?
Sorry, say that again.
First question is, what would you like to ask people to learn more about this?
I guess that it's learn more about like how it affects like different types of relationships and different people outside of like heterosexual relationships. Yeah, so it's like a prevalent issue, and I think like among all types of relationships, and I don't think that's really discussed very much.
It is a very under-researched topic. Second question, can you think of any protective factors that may help reduce IPV in those who have experienced anti-LGBTQ violence as a child?
I wonder if like, I had been wondering if, community connectedness and being like a part of the LGBT community, like as an active part, might be a protective factor. So it was interesting to see Jasmine's presentation and see that maybe like the psychological and minority stress might not be mediated by community connectedness, because I had been wondering if, yeah, like I think that sort of links to what I was wondering about. But yeah, I think it'd be interesting to like explore how like supportive relationships could be a protective factor, and maybe reduce minority stress, which would, and yeah.
Great. If anyone has any last questions, please put them in. If not, we will move on to the next project. All right. We will move on to our next presenter, Maria Nemes. She, they, is an investigator with a Bachelor of Arts in Psychology from Dalhousie University. Maria works as a peer supporter for youth living with mental illness at the IWK Children's Hospital in Halifax, Nova Scotia. They are passionate about 2SLGBTQIA+ and eating disorder research, and have volunteered as a first voice contributor to several research projects and committees since graduating university. Maria's current project is the impact of access to gender-affirming healthcare services on eating disorders concerns in gender minority communities, which is about the relationship between access to gender-affirming healthcare and the prevalence of eating disorders concerns in transgender, non-binary, and other gender diverse individuals. Please welcome Maria Nemes.
Thank you. I'll just share my screen. Can everyone see? I will assume as much.
We can, but I think we're seeing your presenter slide as well.
Oh, that's not good. Let's see if I can fix that.
I mean, transparency in research, right?
Yeah, absolutely. How about now?
Nope, now we just see the slides.
Perfect. All right, thank you. So hey everybody, as I said, my name is Maria Nemes. My pronouns are she, they, and this is going to be my project. For the purposes of this presentation, I'm using the term gender minorities to apply to all genders except cisgender. And I know that's not a perfect term, and I'm open to feedback around other terms of reference, but if there are no strong objections, that'll be my convention for this presentation, as this research encompasses 7 named gender identities and then the entirety of the other category. And also I will be using ED as short for eating disorders. So although this is not a well-studied area of either queer or ED research, some results are consistently found in the existing studies. First, that ED research and treatment is heavily biased towards thin, white, cisgender women, and that inclusive and nuanced understanding of gender plays an important role in the success of ED treatment, and that there's a significant lack of research done on how to treat gender minorities with EDs. ED prevalence has been shown to be higher in gender minorities, which is alarming because EDs have the highest mortality rate of any psychiatric illness, and gender minorities have already been shown to be at significantly increased risk of suicide or self-harm. Therefore, effective interventions in this area are urgently needed. So there are some risk factors for developing an ED that are specific to gender minority communities. These can be influenced in either direction by protective factors against developing an ED or by the reinforcing effects of having an ED. You can see the risk factors listed here in the center. I won't read them out loud. The protective factors on the right are all factors that can do a lot to mitigate the effects of enacted stigma, but you may notice that none of them directly address the issues of body dissatisfaction, dysphoria, etc. On the other side, the physical and hormonal effects of an eating disorder can sometimes be an answer to the risk factors of dysphoria, body dissatisfaction, and the intersectional variable of dysphoria and sociocultural pressure. The point that I'm trying to make is that specific interventions for EDs and gender minorities have to address the specific risk factors. Luckily, there is another potential protective factor identified by research, and that is gender affirming healthcare services for those who want it. The limited research around gender affirming healthcare services such as hormones or surgery and their effect on eating disorders has been promising. Some research has found that transgender people on gender affirming hormones had similar ED rates to cisgender people, while trans people who were not on hormones had higher rates. Other studies have found that access to gender affirming hormones and surgery improved ED prevalence by reducing dysphoria and body dissatisfaction. So far, gender affirming healthcare services are the only consistently identified intervention that addresses the demographic specific risk factors for EDs in gender minorities. So with that in mind, my hypothesis was that people who had been wrongfully denied gender affirming healthcare services would have higher rates of eating disorder concerns than those who haven't. So I used the 2021 version of the Sex Now survey. These are the survey items around gender identity that I pulled the gender minority cohort from. In order to be as inclusive as possible, I created a new variable I called man with trans experience for those who indicated that they were a man instead of a trans man, but then later said that they identified as trans. Anyone who indicated that they had been wrongfully denied any of these services was included in the wrongfully denied group, while those who didn't select any of the items were counted as not wrongfully denied. And eating disorder concerns was a compound variable encompassing anyone who had selected that they wanted help for eating disorders and or body image. So this is a breakdown of the numbers in each cohort I identified, and the eating disorder concern subgroups I compared are in bold at the bottom. So my results. On the left side of the slide, I have diagrams of the wrongfully denied cohort. Eating disorder concerns are the left bubbles and no eating disorder concerns are in the right bubble. On the right-hand side of the slide is the same breakdown, but within the not wrongfully denied cohort. I analyzed my results using a chi-squared analysis and proportion test. And although a higher percentage of the participants in the wrongfully denied cohort reported wanting help with eating disorder concerns, it wasn't a big enough difference for my results to be statistically significant. This is a closer look at the two eating disorder concern subgroups. I ran my data analyses with each eating disorder concern variable individually as well as together. And interestingly, my results were closest to statistical significance when I ran only the eating disorder variable and excluded the body image variable, but I still can't reject my null hypothesis. And there are a few reasons why I think that may be. The first is in the participants that I was targeting in my research. People with eating disorders may not be aware that they have an eating disorder, or they may not be willing to admit that they do to themselves or to others or to a survey. The survey question asks if you want help with these issues rather than if they are simply being experienced. And that is often not the case, especially if ED behaviors are being used to compensate for a lack of gender affirming surgery or hormones. Also, many people hesitate to use the word eating disorder if they haven't gotten a formal diagnosis, and sometimes even if they have. Focusing only on those who were wrongfully denied these services in the past 12 months doesn't account for people who may want access to gender affirming surgeries or hormones, but don't feel safe to ask for it yet, who weren't denied but are experiencing delays in accessing the services themselves, who were wrongfully denied but not within the past 12 months, or who were denied but not wrongfully, i.e. they may have like comorbidities or other health concerns that are getting in the way. I also think that the past 12 months have very likely been impacted by COVID, and that may have impacted people's access to these services. Also, because of Sex Now's design, the survey, no trans women were included in my research, which is a less complete picture than all gender minorities. And there was pretty significant attrition in this part of the survey. Almost 40% of the gender minority cohort had dropped out before reaching the question about wrongful denial of gender affirming healthcare services. So moving forward, my recommendations would be around the ED items on the survey to use more neutral wording. So to ask if people are experiencing struggle with these issues, not if help is wanted with these issues. And also to use the term disordered eating instead of eating disorders, as people may feel a bit more comfortable self-identifying in that way. For the gender affirming healthcare items, I would change the wording of the question to better capture the discrepancy between wanting those services but not accessing them, So I would include questions about other reasons besides being wrongfully denied, like being too scared to ask, not trusting doctors, privacy concerns, lack of info, uncertainty, social pressure, etc. And I would extend the timeline for the question, especially in light of COVID. And yeah, just wanted to say thank you to Emily, Zach, Alex, Naomi, everybody. It was a really great experience and a lot of fun.
Fantastic. So questions. First question. Do you feel there are questions that could be included in surveys that would assess disordered eating without necessarily naming it?
Oh, absolutely. I think that a lot of questions around people's attitudes around food, impact of diet culture, how people feel about their bodies. I think that there could be, dozens of potential directions that it could go in, and it would be more a problem of narrowing it down as opposed to finding questions that could capture that information. But yeah, absolutely.
Another question, why did you include body image as part of your eating disorder concerns variable instead of only looking at the eating disorders survey item?
Right. So I went into this knowing about the potential for ambivalence and denial, especially with the term eating disorders. And I was concerned that people wouldn't self-identify with eating disorder and that I would be missing people who fit the criteria that I was looking for. On the other side, I was also worried about body image struggles being confounded with dysphoria, but dysphoria was listed as like a separate and distinct survey item. So my hope was that participants would view it that way as well. I consulted with a local researcher, Philip Joy, who studies EDs in 2SLGBTQIA+ populations. And he said that my reasoning for wanting to include it made sense. So then I just made sure to run the analysis on each variable individually as well as a compound variable.
Great answer. Here's another question. I'm wondering if you had a chance to stratify the data by racial or ethnic identities. Was there enough data in the first place? If so, what came of that?
I did. What I found was the gender minority cohort was largely white and largely under the age of 40. All of my subgroups were representative of that in the same way. There were no really significant differences. But when I compared that with the entirety of the Sex Now survey participants, there were not really significant differences in that way. The gender minorities cohort was slightly less racially diverse, but it wasn't, there was no real significant differences in terms of like race or age that I was able to observe in any of the subgroups.
Thanks for clarifying. All right, we'll give just a little bit more time for questions before we move on. Thank you, Maria.
Thanks.
The next project is a group project. So I'll let Emily introduce one of them and I'll introduce the other.
So the first participant of this group of two is Yejin. So Yejin is using she, her pronouns, is a transfer student from America who's currently doing her undergraduate degree in psychology at Mount St. Vincent University, aiming to work in a mental health field. She currently lives with her partner and her cat in Halifax, Nova Scotia. As a woman who is part of the LGBT community and a visible minority, she recognizes that there is a growing need for inclusivity and research for the specific contexts and factors for mental health for minority groups. Accordingly, she wishes to address barriers in access to treatment and the gaps in research that remain to institutional blind spots to the specific needs of under-researched groups.
Andy, she, her, currently lives in Halifax, Nova Scotia, where she was born and raised for most of her life. She is doing her undergraduate degree in psychology and women's studies at Mount St. Vincent University. She plans on working in mental health with an emphasis on issues surrounding gender and sexuality. As a queer person of color, she thinks it is important to take an intersectional approach to research to better address the concerns of marginalized peoples. It is important to include members of the groups being studied in their research process, which is why she is looking forward to doing further research on the groups to which she belongs. The group project is called Reconceptualizing Body Image and Eating Disorders for GBQM, and it will discuss the pervasive biases in research surrounding gay, bisexual, and queer men with regards to body image and eating disorders, and alternative frameworks for more effective treatment modalities. Without further ado, please begin.
Hi. Hi. Can you see our presentation?
Yes.
Okay, thank you. Okay, so hi. Once again, I'm Yejin. And I'm Andy. And our research, Reconceptualizing Body Image and Eating Disorders for GBQM, focused on examining biases in healthcare towards gay, bisexual, and queer men, and the negative impact this holds for their eating disorder treatment. Our goal was to assess whether eating disorders and body image disturbances are more associated with internal pressure from the gay, bi, and queer male community, or from external societal factors. We also looked at alternative pathways for more effective therapy modules for this population. So eating disorders are a major public health issue with high mortality rates and many adverse long-term health outcomes. Gay, bi, and queer men are at a higher risk of developing eating disorders and body image issues compared to heterosexual men, with 14% reporting having had a history of eating disorders and another 1/2 reporting significant clinical risk factors for developing one. However, the research on this subject overly focuses on how problematic body and eating norms are within this population. This emphasis, unfortunately, is linked to stereotypes of gay men's concerns with appearances as being perverse. Thus, we want to examine the factors contributing to eating disorders without also contributing to homophobia. So in our literature review, we did find that there is a widespread ideal of a thin, white, masculine body within this population, but there are also diverse body positive subgroups like the bear community. Thus, a better framework to look at this issue is with the minority stress model, which states that body image issues and disordered eating stems from the added pressure to conform to societal expectations when you already belong to a marginalized group. Then there's also childhood trauma, which significantly predicts disordered eating, since these can be used to try to cope with intense negative emotions related to unresolved traumas. Also, we found that having a caring relationship with one's body and developing effective emotional regulation skills are associated with better eating disorder treatment outcomes. Since this population often have not developed these due to household dysfunction, minority stress, and childhood trauma, we concluded that it would be best to develop therapy modules that center on improving self-compassion, body appreciation, and emotional self-regulation for this population. Also, mental health clinicians should become well-informed about the specific issues faced by gay, bi, and queer men to best facilitate treatment. So for our methods, we used data from the 2019 Sex Now survey to analyze the relationships between experiences of discrimination and trauma among this population and eating disorders, as well as body image issues. The survey includes questions pertaining to the health and well-being of gay, bisexual, transgender, two-spirit, and queer men and non-binary peoples. We used multiple chi-squared tests of independence with the R statistical analysis program.
So there were a total of 14,364 respondents on the 2019 version of the Sex Now survey, and all of the respondents were from across Canada. There were varying ethnicities, sexual orientations, and gender identities. Ethnically, the majority identified as white. In terms of sexual orientation, most of the participants identified as gay, and most of them also identified as men. We found significant results for all of the chi-square tests of independence that were conducted. This means that we have strong evidence of a relationship between eating disorders and negative life experiences in gay, bi, and queer men. The experiences that we looked at included feeling pressure to be masculine from friends and family, from other gay, bi, and queer men, and from society as a whole, having gone through conversion therapy for sexual orientation or gender identity, being discriminated against for body type from society as a whole or from gay, bi, and queer men, having gone through intimate partner violence, whether that be physical, verbal, or sexual, having gone through anti-LGBTQ2S violence, whether that be emotional, physical, or sexual, and having gone through traumatic sexual experiences. Our results are consistent with previous studies that showed an association between eating disorders and gay, bi, and queer men with different developmental and psychological causes. And these results show that just because someone is a part of this community, that doesn't mean that this is the cause of their eating disorder. We also want to highlight the importance of eliminating negative stereotypes surrounding this community in the healthcare system, because these stereotypes reinforce the idea that the standards in this community cause eating disorders among its members. In terms of limitations, due to the nature of the Sex Now survey, we weren't able to find the actual number of respondents who had eating disorders, and this is because the question that asked about eating disorders asked if people wanted help with an eating disorder and not if they had one. So we might have missed out on people who didn't want help with an eating disorder or who didn't know that they had one. Also, we didn't look at experiences relating to race, ethnicity, class, etc. So we may have missed out on other forms of trauma or repression. And future studies could address these limitations to help further the knowledge about this subject. To conclude, we hope that this research will contribute to the knowledge about eating disorders among gay, bi, and queer men. And our results also show that it's important to tailor therapies to this population based on their unique life experiences, especially those that relate to homophobia. And hopefully this research will help promote more activism and acceptance of gay, bi, and queer men with eating disorders. Thank you.
Great. If anyone has any questions, feel free to post them in the chat. How can mental health clinicians make eating disorder treatment more welcome to GBQM in practical terms?
Well, we do want to encourage clinicians to really study how mental health specifically impacts their treatment alongside with their specific experiences as a sexual minority, but also recognize that you can't generalize studies until an individual person, but also treat them as be sure to just treat them with respect to their own individual experience and tailor your treatment with recognition towards that.
All right, next question. Any thoughts on the hidden epidemic of disordered eating in queer men who are trying to look fit / swole, etc., to attain unrealistic fitness standards?
Yeah, we did see that is we did see that there is a prevalence for being fit and being thin and really masculine. But we also did find lots of diverse other subgroups like the bear community, which has more of an emphasis on bigger bodies and not so much a focus on being thin. So we just feel the research has overly focused on the gay community focuses too much on body image when that's not the total picture.
Yeah, and I also think that research about this could go into the causes, whether that be from standards in society as a whole. I think that a lot of those societal standards kind of trickle down and they're transformed within the queer male community as well.
Great. Just give a couple more seconds for any last minute questions and then we'll move on. Oh, here we go. Do you think there is a difference in how GBTQ men perceive their bodies in relation to their gender presentations? Example, more masculine versus more feminine versus non-binary.
We were thinking of analyzing that, but we weren't able to at this time. The Sex Now survey did like differentiate like pressures to feel masculine and feminine, but we weren't able to get to that part. But it is a really interesting aspect, and in our further analysis of this topic, we do want to like look at that. So.
Great. All right. We're going to move on to our last presenter now.
Alrighty, so last but not least, we're going to have Karen present. So Karen Stewart-Kirk, who uses they, them pronouns, is an aspiring researcher and has worked on several health outcome-focused projects with the intent to use the voices of participating community to inform infrastructural change to better provide solutions and prevention plans to foster healthy communities. They moved from rural Alberta to Prince Edward Island to obtain a Bachelor of Applied Science from the University of Prince Edward Island, and then went on to complete a Master of Public Health from Western University in London, Ontario. In today's summit, they will be presenting on their findings from the 2021 Sex Now survey, describing the significance between PrEP initiation barriers by population density across Canada within the LGBTQ+ community. In their spare time, Karen trains for triathlons and hangs out with their cat.
My apologies. Let me try that again. How's that look? Can you see that okay?
We can also see your presentation notes.
How about now? Does that change? Or still yes?
Something's happening.
Something's happening. That's exciting, maybe. Let me try one more time. Maybe it won't hurt to try again.
It never hurts to try again.
I'm determined, very perseverant. How does that look? Did that work?
We can still see your slides, but that's okay.
Ah, darn. How embarrassing. What if I solution oriented? I do apologize also because everyone made such beautiful PowerPoint presentations and I made a poster and I like my poster. I think it would be really nice to have printed it and presented it physically in an in-person conference. But it's a teachable moment, I think, for everyone. Now, how does that look? Is that any better?
Yeah, that's your poster. We can see it.
Let's go. Okay. I won't take up any more time. Let's get started. Canada source
Your
for
poster
HIV.
went away.
No!
I think maybe you went forward one slide.
One step forward, two steps back. How about this? How about that? Did that work?
Well, we see it, but it's within PowerPoint.
No, wait, if it was, that's gotta be close if it was within PowerPoint, right? Because then that just means.
Can you go back one slide? Is that
go back? It's one slide.
Because we're seeing, there we go, perfect.
Hey, I like to use my time really efficiently. All right, let's get started. Is it okay to start?
Go ahead.
Yeah, let's go. Canada's source for HIV and hepatitis C information estimates 62,050 Canadians have human immunodeficiency virus or HIV, and of this population, 87% are diagnosed, 85% of those diagnosed are on treatment, and 94% of those on treatment have achieved viral suppression. In other words, they're not cured of HIV, but the amount of HIV in the blood is so small that it's not detected by standard blood tests. Surveillance from the Public Health Agency of Canada highlights a 21% decrease in new diagnosed HIV cases in 2020 from 2019, of which 60.8% of these cases were reported from male-to-male sexual contact exposure. Moreover, previous research indicates new diagnosis rates varies most based on age and lived environment. Although approved for use in 2012 by the Food and Drug Administration in the United States, the Canadian Drug Expert Committee did not provide an official recommendation to participating Canadian federal, provincial, and territorial public health providers to list prescription generic brand pre-exposure prophylaxis or PrEP in their drug plans until 2016. Even then, this recommendation came with two conditions that ultimately served as barriers to PrEP access. One being that PrEP had to be provided in the context of a sexual health program by an experienced HIV prescriber, and two, that the price must be reduced, hence the limited availability of brand name PrEP. Medical indication is the term used in healthcare practice to describe the condition in which a valid reason to administer a test, procedure, or treatment is present. Men who have sex with men have high incidence or high probability of contracting HIV and are therefore medically indicated for prescription PrEP treatment. For those who have never heard about it, PrEP is a highly effective medication to prevent infection of HIV upon exposure. However, studies continue to highlight suboptimal access to PrEP. Structural barriers that have been previously shown to perpetuate systemically inadequate PrEP access include financial constraints, such as limited healthcare coverage, burden of travel, and insufficient health utilization, particularly among men who have sex with men who are Black, Indigenous, and persons of color, those who are uninsured, living in non-urban communities, and who are under 25 years of age. Additionally, cultural and political barriers exist, such as the inconsistent knowledge of PrEP among healthcare providers. Comprehensive HIV and PrEP education are typically extracurricular if offered at all during a medical student's time in school, impacting the level of care a physician is able to provide for their patients. Previous literature highlights existing patterns between population density of one's lived environment and PrEP access barriers. Prior to the introduction of PrEP, condom promotion was considered the gold standard of HIV-related public health practice, and while condomless sex is still considered a risk behavior, and seroprotective behaviors, such as reducing one's number of sexual partners or only having sex with partners whose HIV status is known, are encouraged by practitioners, it is well documented that PrEP use, especially persistent daily use, is more effective at reducing HIV transmission, even when condoms are not used. Still, PrEP does not protect against other sexually transmitted and bloodborne infections and can come at a great cost to users, including the financial constraints of those without insurance or the time and resources required to commute to a clinic for testing. It is important to acknowledge that being able to take time off work or other commitments in order to visit a clinic or accessing a vehicle or even the availability of public transit all impact one's ability to access health resources. This is especially true when considering the short and long-term side effects of PrEP use, which require frequent clinic visits for testing, making PrEP adherence challenging. The social determinants of health include the economic, physical environment, education, and context of one's community and healthcare environments, which all play a role in one's health outcomes. The education of prospective PrEP users is linked with PrEP initiation. In other words, those with more formal education have a greater chance of learning about and therefore accessing PrEP, but further still, education of HIV and its risks have an extensive history of being documented in a biased and partisan fashion, allowing stigma to fester within medical and social communities, causing further harm to those that already have little reason to trust those who are responsible for their care. Those living in rural and remote communities have unique challenges to receiving care, and compared to their urban and suburban counterparts, previous research has classified rural and remote communities as PrEP deserts based on travel requirements to reach nearby clinics. And it is documented that even when access to PrEP is made available for them, their PrEP use time is harder to sustain than their urban and suburban counterparts, in spite of having similar PrEP to need ratios. There are several potential and interacting reasons for this, including concerns over privacy when living in a small and tightly knit community, in addition to greater instances of lower household income and education among these communities. Using the community-based research center's SexNow 2021 survey data, we chose to explore PrEP access by lived environment in relation to reported PrEP initiation barriers. Given the complexity of experiences in accessing PrEP, it is important for researchers to include an in-depth analysis of barriers that range from internal to external causes that may be influenced or in turn influence the population density of one's lived environment. In identifying commonly cited barriers for PrEP initiation by lived environment, health practitioners can potentially meaningfully tailor their care plan and engage in the risk reduction of HIV transmission. Moreover, policy decisions can be informed from highlighted PrEP access discrepancies regarding PrEP education and distribution. The only lived environment that contained PrEP access barriers with no responses was from those living in remote areas, yet this demographic still had the highest average percentage of responses. I'd rather use condoms, it costs too much, and I'm now in a monogamous or closed relationship had the greatest range in responses, with each barrier being the most cited by those in remote areas. It's important to consider the interconnectedness of these barriers. For example, condoms can be purchased readily from a variety of locations or even found for free at healthcare clinics, but PrEP can be expensive even with a prescription. In spite of the low reported incidence of lost health coverage due to COVID-19, there still could be a relationship to PrEP access considering the impact that the pandemic had on the availability of healthcare services, even among those with insurance, which could have an influence on the choice to reduce sexual partners or keep sexual relationships closed to reduce risk of HIV transmission and other sexually transmitted and bloodborne infections. This may have a relationship with why I reduced my number of sexual partners was consistently reported regardless of lived environment. Although there does appear to be some population density influence in PrEP access barriers, each barrier has a general consensus in terms of its relevance. This tells us that population density alone, while a useful piece of information for researchers to use for understanding and exploring distribution of health resources, is incomplete when considering that geopolitical influence by province and territory, immigration status, indigeneity, or even at a neighborhood level must be accounted for when considering factors that contribute to healthcare access among Canadians. Given the time frame, choosing lived environment to demonstrate the broad differences served as the most meaningful tool to open doors for more in-depth research to take place and further identify solutions to cited PrEP access barriers and thus aid in the reduction of HIV transmission. Further research is needed to explore the nuances of PrEP access barriers that may be perpetuated by population density, including assessing cultural competencies among healthcare practitioners who provide care within locations by varying community influences such as religious affiliations, age distribution of the population, and the political climate. Thanks so much. I have a few minutes now, I think, for questions.
Yes, any questions, please place in the chat. First question, what do you see as potential solutions to PrEP deserts, sorry. Oh,
yeah.
no,
Absolutely. A big thing with rural and remote communities, and as I mentioned in the beginning, is that PrEP can only be given or distributed or prescribed by an experienced HIV prescriber. And I think one way to resolve this distribution error of PrEP deserts would be by increasing education among general practitioners or family doctors. So that there is a better chance for prescription to be accessed for individuals instead of needing to find specialized care.
Great. Any other questions? Oh, here we go.
Probably tastier.
PrEP deserts would, never mind, that's my question.
I can provide my email with more questions too, because I have a lot more data that I looked at and I just chose the stuff I thought was most exciting.
Of course.
Ooh, yes, I do. I do think that because if general practitioners and family doctors had the means, or even imagine if like even an emergency doctor could give out PrEP. I think they can hand out PEP. Maybe don't quote me on that. That's only based on my my own experiences here in Nova Scotia, but I don't know what it's like on a provincial or national level. Any reflections on services like Freddie and how they could make them more accessible to folks in rural environments? Yeah, it's so complicated, right? Like what I was saying, there's issues with transit, right? I don't know if you know what it's like living in a rural area, but sometimes when you don't have access to a car, but you want to take public transit, it doesn't run on certain roads or certain times. So I think not only making it more accessible by who can prescribe PrEP, but I think the physical access to the building to get your medication would make a huge difference. Online PrEP prescription service. Oh, that's really exciting. Things like that would be really cool, especially thinking about remote and rural communities being able to access online. I know there's people in Canada who don't have access to the internet, but internet can be available for people even when they're able to go to like the library or other social services. Had to delay rollout. Yeah. Did I miss a question? I hope I didn't.
No, you didn't miss anything.
Okay.
All right, we'll give a few more seconds.
Great job to
and
Tyler
then
for
we
keeping up
will-
with me.
Okay, we will begin the wrap up. So I just wanted to congratulate each and every one of you. You all did fantastically. Honestly, I think that you were more engaging than most professors I've seen. Thank you everyone for coming out and taking part in this year's Investigators webinar. We hope you enjoyed the hard work from all of our presenters today. And if you wish to get into contact with any of our presenters to discuss their project, please let us know. You can send an email to zach.crawford@cbrc.net. I'll just place that in the chat quickly. And if you all want to, just take a bow. You worked hard tonight. All right, that concludes our webinar. Oh, and do feel free to answer our survey. It'll be emailed to you. It just helps us improve things for the next round.